Hello and welcome to this episode of Health and You. I am Sumi Sukanya Datta, and today's topic of discussion is antimicrobial resistance or AMR, when disease causing pathogens such as bacteria no longer respond to antibiotics and can cause severe infections and deaths. To discuss this, we have two illustrious guests, Dr. Kamini Valia and Dr. Arvind R. Dr. Valia heads the AMR division at the Indian Council of Medical Research, and Dr. Arvind is a senior infectious disease specialist who is also convener of the Kerala Action Plan on AMR. Thank you, Dr. Valia and Dr. Arvind, for joining us today. We'll start by asking you, Dr. Valia, can you please help us understand why has AMR emerged as a global public health emergency, and why is it particularly a challenge in the Indian context?
Thank you, Sumi. So antibiotics were discovered many years ago, and when the antibiotics were discovered, they were actually the panacea, and they formed the foundation of modern science. Now,
Right.
modern medicine. So now what we are seeing is that the antibiotics, or what we call as antimicrobials, are not effective anymore.
Right.
The pathogens or the bugs are actually becoming resistant to these drugs, which we call as antibiotics or antimicrobials, and we are not able to treat infections which are caused by these bugs, which are resistant to these drugs. And last few years, we have seen and we have recorded and we have evidence now to say that there is a rampant antimicrobial use, especially in a country like India, and also many other countries globally. And to a large number of antibiotics, the bugs have now become resistant. So that is a cause of alarm. Plus, the new antibiotic pipeline has been running dry, and that has been one of the major concerns that the entire medical fraternity and the public health fraternity is actually concerned about the increasing levels of antimicrobial resistance, and everyone is worried that how we will be treating infections in the years to come. Plus,
Yeah.
there is a very high mortality, which has been documented by various reports which have been published in last few years. So which goes on to show that the burden of antimicrobial resistance is said to be very high, especially in low middle income countries. And the countries have to take immediate steps towards containment of AMR.
Yeah. Dr. Arvind, why do you think we have reached such a position? You know, when penicillin, when it was discovered, was considered, like ma'am also mentioned, as the greatest discoveries in the medical sciences in the 20th century. But why have we really reached this position that superbugs are threatening to sort of disrupt the way we live?
First of all, thank you, Sumi, for having me on a show. And that question is a bit tricky because, antibiotics or antimicrobials are the compounds which are actually present in the environment. So these are synthesized by bacteria or fungi in the fight against each other. So basically what we are doing is we are accelerating the process of antimicrobial resistance through the unscrupulous use of these valuable drugs, that is antibiotics. So basically, for example, when penicillin was invented, penicillin is an antibiotic in 1960. So the first the isolate of MRSA was discovered in 1961 itself. So that means that it's continuous race between the humans and this bacteria and fungi. So it's actually a sort of an evolutionary pressure on them. So the more antibiotics we make them exposed to, the more chance of them developing resistance. So the strength of bacteria or fungi is to mutate, that is evolve and become resistant to the antibiotics or antimicrobials. And our strength is actually in outpacing them and coming out with new antibiotics. So, but then that will take a lot of times, coming with a new molecule, getting all these approvals, regulatory framework is there. So that is why, Kamini madam said that the antibiotic pipeline is sort of a dried up sort of thing. So that is also very important. So because as part of evolution, antimicrobial resistance is inevitable. So in order to keep one step ahead of these microbes, we need to invest more and more in research and come out with new molecules. And till that time, we have to ensure that whatever valuable antibiotics are left with us, so we need to have stewardship practices so that we are not exposing these microbes to more and more quantities of antibiotics. That is why we need to have a One Health framework. So antibiotics are being 70 to 80% of antibiotics are being used in animal husbandry. So we need to address this problem of AMR from a One Health perspective. So that is actually the only way out. And unfortunately, the gamut or the the full brunt of AMR is felt by the Southeast Asian countries, as Madam suggested, the low and middle income countries, and these are the countries which lag behind in research on coming out with new antibiotics, and we are dependent on the West to have new antibiotics. The regulatory framework is so stringent and sort of things like that. So it is actually our role to ensure that the antibiotics that we have access to now. So we need to ensure that these drugs are being used responsibly by all the stakeholders, by the human side, animal husbandry side, fisheries and aquaculture, environment, etc., so that till we come out with newer molecules, our lifeline is the drugs which are already left. So this is a very tricky question, because the studies have shown that even from Egyptian mummies and caves in Mexico, where that humans have never gone, they have isolated these antimicrobial resistant bugs. So that shows that humans are just one part of the problem. So basically, what is happening is evolution is going on, and we are actually adding fuel to the fire of antimicrobial resistance through the unscrupulous use of antibiotics.
During the COVID pandemic, we saw a lot of use of antibiotics by everybody who had fever. Even now, whenever people have fever, cold, they just tend to take things like azithromycin without even asking the doctor sometimes. Do you think COVID may have sort of in a way worsened it? Or if I can put it the other way, had COVID not been there, would the situation would be any better than it is there currently? Dr. Valia, would you like to answer that?
Yeah, so in COVID, we definitely saw deprioritization of antimicrobial stewardship efforts, which we were undertaking in all the hospitals where ICMR was funding antimicrobial stewardship projects. What we saw was that most of the staff actually was directed towards management of COVID patients, and that led to even the research staff being diverted towards the COVID patients. And that's why the antimicrobial stewardship efforts, which were there, were getting deprioritized. They were not getting enough attention. The second point is that in the hospitalized patients or in the patients who were in the community, I mean, the scare of COVID was so much, and we did not have any specific treatment for COVID. So,
Right.
I mean, because of that, frenzy, I think the populations or the communities were consuming a lot of antimicrobials. Steroids, antimicrobials, these were the two drugs which saw a definite increase in terms of their prescription as well as consumptions, which is a well-documented data.
Right.
But in hospitalized patients, what we saw was, and this was the study which was also published by ICMR, that the incidence of secondary infections was not much higher than what we see normally in the patients with respiratory infections or with flu infections. Yet, I think it was the scare of the COVID and absence of any specific treatment which actually drove or increased the prescription of and consumption of antimicrobials in COVID patients.
Yeah.
But if you see the recently released Lancet report, they have reported that during post-COVID, there is a small decline in terms of mortality because of infections. So this is a phenomena, I think, which we will continue to study for a few more years, that what did COVID actually contribute to antimicrobial resistance. From the ICMR data, what we see is that there was a short-term uptick in terms of the increasing trend. Increasing trend of drug resistance to some of the antibiotics, but it came to normal after 2 years of COVID. So that's why I say, I mean, it was, I think, a temporary setback, but wherever we were having good efforts of antimicrobial stewardship which were going on, ICMR network hospitals, I think, stuck with it, and they continued that, except with few hospitals. Other than that, I think COVID led to temporary setbacks, but sustained efforts on antimicrobial stewardship has led to not very major setback in terms of the loss of focus on antimicrobial stewardship.
Okay. Dr. Arvind, would you also like to add something to it?
Actually, COVID was an opportunity because all of us are working on antimicrobial resistance and mitigating strategies, sort of thing. COVID was an opportunity in the sense that majority of the antibiotic prescription happens in the outpatient department. And
Right.
one of the arguments that doctors make is that in India, we don't have access to diagnostics in the OPD setting. And that is the reason why we are forced to use antibiotics, even means for apparently respiratory infections, 90%
What
of
we
them.
call empirical use of antibiotics.
Exactly. So they don't know whether it is a bacterial or viral infection, and that is the reason why they are using antibiotics. That was their explanation prior to COVID. But COVID time, it was actually the first time that as clinicians we knew the diagnosis before starting a drug, because all of them we had that much access to, thanks to ICMR and their network. We have that much access to molecular diagnostic facilities. So all of us knew that we are treating COVID-19, that is a viral infection. Despite that, azithromycin became the largest selling. This azithral became the largest selling brand in 2022, 2023. And their sales were more than 1,000 crore. That is more than the sales of insulin, human mixture. So that means that despite knowing it is a viral infection, doctors did still use antibiotics. That means that it is not because of lack of awareness that they use antibiotics. Okay, so that explanation was gone. So from a stakeholder perspective or a policymaker perspective, then we realize that we need to be that much serious about antimicrobial stewardship. So we have been talking about information, education, communication, but that has to translate to BCC, behavioral change. For that, knowing a diagnosis alone is not enough. That is what COVID did teach us. So we need to engage more with the clinicians. We need to engage with the public. We need to engage with the civil society. Knowing a diagnosis of a viral infection alone did not change anything with regard to the prescription practice of doctors in India. That is what I understood from the sales of azithromycin. So one aspect could be because of panic, but despite having a diagnosis, still antibiotics were used. So based on that, we actually changed our strategies in antimicrobial stewardship in our state. And the Lancet report, to an extent, is actually correct that in initial period, that is 2020, 2021, because of lockdowns and all those things, and we were so strong about infection prevention and control, hand hygiene and stuff like that, all the respiratory infections across the globe had come down in 2020, 2021 because of all these, mitigation measures. And because since the other respiratory infections came down, the antibiotic use also might have come down, and that is probably reflecting in the Lancet report. But that was not the situation during the Delta wave. That is 2022, 2023. Actually, it came back with a vengeance. That is our experience from our state. So for 1.5 years of COVID, the antibiotic use was very low in the state, but then it came back with a vengeance and it became sort of normalcy. And as Kamini madam said, it will take us years to understand what the contribution of COVID to, the silent pandemic of antimicrobial resistance in our country.
Yeah. Dr. Valia, this question is for you. The ICMR recently came up with this annual AMR Research and Surveillance Network report. Could you help us understand what is this report about and what were the key findings that we must know?
So this report we publish annually. This was the 7th report that we had published from the ICMR AMR Surveillance Network, which was established in 2013. So we report the trends of antimicrobial resistance to key pathogens. For example, Escherichia coli, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, then Salmonella typhi, diarrheal pathogens like Vibrio cholerae, Shigella, Aeromonas, and we also report trends for the fungal infections. So we report trends for these key pathogenic groups from the tertiary care hospitals of the country. So as I mentioned, this is the 6th report. The idea of publishing is that, all the physicians know that what kind of trends we are seeing in the tertiary care hospitals. Okay. Now, the tertiary care hospitals mostly receive very sick patients, or most of the time they are also treating patients who are referred from other health facilities. So the AMR trend, which is rates which are reported by this report of ICMR, they are actually very high. They are not reflective of our mid-level hospitals or the community levels So this has to be taken with a pinch of salt, that okay, this is a high this is coming from a setting which where the antimicrobial use is very high, so correspondingly antimicrobial resistance rates will also be high. Now what we are seeing is the findings from the report are, they are not much different from what we are seeing for last 4 5 years. uh, E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter, and Staph aureus, they cause almost 80% of the infections if we look at it in terms of their contribution to the total number of drug-resistant infections reported by the network. And these are
Right.
the gram-negative pathogens. 4 of them are gram-negative pathogens for which we are running out of treatment options. The resistance rates to carbapenems, piperacillin tazobactam, and other cephalosporins is very high. And as a result, if the
For
patients
the
get these
context, I'll
infections,
add here that these are the last resort antibiotics which are
yeah,
which you are
yeah.
talking about.
So when the
Carbapenem.
patients get these infections which are caused by these drug resistant pathogens, then they have very limited treatment options. So the message that we want to convey through this report is that the broad spectrum use, which is very high in our country, we need to bring that down, because that is adding to emergence of multi drug resistant pathogens that are becoming very difficult to treat, and those patients have very limited treatment options with the drugs that are currently available in India.
Right. Dr. Arvind, would you like to talk a little about the Kerala action plan? Because, it has taken a lead in the country in a sense of, introducing several measures to bring down the rate of antibiotic use. Yeah, Dr. Arvind, yeah, please go ahead.
Actually, when the National Action Plan was launched in 2017, Kerala became the first state in the country to have its own state level action plan. It was released in 2018. So, on par with the Global Action Plan and National Action Plan, we have 6 strategic priorities. The strategic priority one is actually, creating knowledge and understanding among all the stakeholders. And second is
Right.
actually, the evidence. Evidence creation means just like the ICMR network, we have our own network, that is the CARSnet, which has around 52 tertiary care centers, and we have the hub and spoke model as well. Third is infection prevention and control, which is very, very important because, Madam said that the rate of resistance in tertiary care ICUs is very high. That means that we can't afford to have any healthcare associated infection occurring in majority of our tertiary care institutes, because if it is going to occur, it is going to be by a drug resistant organism. So that we need to focus that much on infection prevention and control. Fourth is actually antimicrobial stewardship, that is the judicious use of antibiotics in the OPDs, in the inpatient department, as well as in the ICUs. Fifth is research. Research is the most important thing. So we are basically clutching on to whatever is available to us till we get newer products. So that has to be our vision. And sixth is actually public-private collaborations. So as part of this, our action plan, the second one is the most important one, which I feel like, having our own surveillance network. So that is,
Right.
our surveillance network is the CARSnet, Kerala Antimicro Resistance Surveillance Network, and we feed to the NCDC. NCDC has their own surveillance network. From there, the data goes to the global. That's the GLASS portal. It goes to the GLASS portal. So initially, we started with the government medical college. Then we expanded to the private medical colleges, the corporate hospitals, and now we have around 52 sites, nodes reporting to us. Then we realized that our antibiogram, there is a state antibiogram from our tertiary care centers, is actually a bit different to the ICMR. The resistance rates are actually is high, but still less compared to the resistance rates report from the centers in the ICMR network. That is understandable because majority of the centers reporting to the ICMR are top-notch institutions like VGH Chandigarh or AIMS. They will be having more complex surgeries and patients on chemotherapy like that. So basically, we understood that the resistance is going to be different and is going to vary from institution to institution. So we understood that based on the Trivandrum Medical College antibiograms, I represent Trivandrum Medical College, which is actually a high-end center. So there the rates are high when compared to another medical college which doesn't do that much of complex surgeries or chemotherapy, etc. So we decided that each institution should have its own antibiogram. So otherwise, if you follow our antibiotic policy, it might drive up the resistance in another center like that. Then we realize that if this is the situation between tertiary care institutions, then what about the secondary care and the primary care? So for that, we started the hub and spoke model. Hub and spoke model means that in all the districts, we will identify an AMR center of excellence. That will be a district lab or a public health lab, and that will be having all the automated facilities. And that will act as the hub. And the spokes will be the taluk hospitals. So we piloted that in Ernakulam from 2019 onwards, and we came out with the district antibiogram. And interestingly, the district antibiogram showed that, the meropenem is our last line antibiotic, right? So at the taluk level, we don't have any meropenem resistance. That is what the 2022 antibiogram at the district level showed. And this actually has to be extrapolated to the rest of the state as well. So we have established the hub-and-spoke model in all the districts, and next year we'll be having this district antibiogram from the 14 districts of Kerala. And ICMR also is actually taking the lead in establishing this hub-and-spoke model of surveillance in other states as well. So from an India perspective, this is going to be very, very important, because one network may not reflect what is happening at the secondary level or the primary level. So based on that, we need to have stratified antibiograms. So that is antibiograms based on the data from individual institutions or from the secondary care, primary care. And we need to have the stratified antimicrobial stewardship intervention strategies. And that is what we are doing in the state. For that, we have a decentralized approach towards antimicrobial stewardship. We have the district level AMR committees. We have the block level AMR committees in all the 190 blocks. And then in 2019, we came with the concept of antibiotic literate Kerala, because so we saw that, despite knowing it is COVID-19, antibiotic was used, right? So in order to ensure that the antibiotics are not being prescribed, there are two aspects to this. One, even if the doctor is not prescribing, the public might demand an antibiotic. That is what majority of the doctors said. So basically, the awareness creation has to be targeting the healthcare professionals, need to target the students, the schools. School education should, have aspects of AMR into that. We need to educate the farmers, we need to educate the civil society, and we need to reach out to the public. We do that through the block level AMR committees with the family health centers as the fulcrum. So basic aim is that everyone should know about the right use of antibiotics, and antibiotics should not be used without prescription like that. For that, we need to have a bit of legislation as well. And we know that Schedule H1, all these things are there. The implementation is the challenge. So from last year onwards, we started this Operation Amrit, whereby a toll-free number was given to the public. That is, all the pharmacists have been instructed not to give antibiotic without prescription. But the issue in India is that we have enough very good laws, but implementation is the problem, right? So we may not be having that much number of drug inspectors to see whether this is being followed up like that. So what we did here was we gave a toll-free number to the public. Suppose someone is going to the pharmacy and getting an antibiotic without prescription. If he is an antibiotic literate citizen of Kerala, he can use this toll-free number and inform us. So after that, there was a huge drop in the sale of antibiotics in the state, but it did not reflect into mortality sort of thing, right? That means that if everyone is educated, we can really bring down the quantum of antibiotics which are used without prescription. So it has to be a multi-pronged strategy, because focusing on the human side alone is not going to be enough. So it is a one health thing: animal husbandry, the fisheries and aquaculture, environment, everyone has to be in it together. So what we are doing in Kerala is that we have trying to identify all the challenges and trying to go with the customized solutions for that in a one health fashion.
Very interesting points there. Dr. Valia, could you summarize, what do we as individuals need to do, what doctors, because we have seen that on many occasions, even when it's not required, doctors also indiscriminately prescribe antibiotics, and also, what policy measures you think are immediately required to address this major crisis?
So, and the whole genesis of this antimicrobial resistance is because there is a lot of antimicrobial pressure. Now,
Right.
if we really want to contain antimicrobial resistance, we have to bring down this antimicrobial pressure, and we have to look for interventions. How can we reduce this antimicrobial pressure? And instead of running towards developing new antimicrobials, as Dr. Arvind very nicely pointed out, that we must prioritize rationalizing and having a responsible use of existing antimicrobials, because it becomes a way of consuming antibiotics now, currently, as he has very rightly said, that it is very hard to implement the even the policies and the laws which are there, because somewhere there is a very poor threat perception, that improper use of what will be the consequence of irresponsible and improper use of antimicrobials in future. We are realizing it, but very few our stakeholders or even the community members are actually aware of big risk that it poses for future medicine. So for prevention, I think we should be using the what we have right now optimally, and for that, I think vaccination is very very important. What we see is that for the prevention interventions, the vaccines that we currently have, we are not utilizing them optimally. For example, WHO says that 75% of the adults in any country must have influenza vaccination. But in how many countries do the elderly people who are 75 plus actually take, or all the adults, they take these influenza vaccination? It is available in India. Pneumococcal vaccine is available in India. We know now that respiratory infections attract maximum number of antimicrobial prescription and antimicrobial consumption in the community. So if everyone starts using the vaccines appropriately, we can bring down the incidence of infections which would require antimicrobial prescriptions. This is one example
So,
which we can.
just a supplementary question there. Do you think it will help if these vaccines, for example, are introduced in the government's universal
Uh,
immunization program?
Definitely. ICMR is undertaking a study where we are going to monitor the impact of introduction of flu and pneumococcal vaccine in elderly population, and its impact on the hospitalization, mortality, as well as antimicrobial prescriptions. Now we are going to be, a country. The demography is going to be changing. We are living longer, so the
Right.
longer we live, more infections we are likely to have, and the more antimicrobial resistance. The other intervention is reducing the use of broad spectrum antimicrobials. I think we need some kind of a campaign in the country for physicians, for community, that we do not need to overprescribe broad spectrum antimicrobials. That this is something that we cannot afford. It is not a choice anymore. I think we do not have any other option but to bring down our broad spectrum antimicrobial use, for which we need to monitor our consumption, for which we need education and awareness. So in India, we have an issue of access versus excess. So there are populations who do not have access to even the basic antimicrobials because they cannot afford, or they do not have access to the healthcare facility. On the other side, we see excessive use of antimicrobials because of rising standard of living, improving incomes, and also the cost of antimicrobials has been really brought down by efforts of the government to make them affordable. But then this should not really impact the antimicrobial resistance containment effort. So that's why these are the multiple. I have just talked about a few of them, but these kind of interventions, I think they can contribute a lot towards our AMR containment efforts.
Yeah. Thank you so much. With that, we come to the end of the discussion. I really appreciate both of you joining us in the discussion today. Thank you so much, Dr. Valia and Dr. Arvind.